Hi, good evening. This is Dr. Maria Sophocles. Thank you for joining me for another episode of Gynecology, where we try to dig into some of the um, healthcare issues that patients want to learn about. And it's Pride Month, so I always think it's important to not forget our transgender patients who often struggle to find a healthcare provider or clinic or surgeon. I think it's important to have an episode of Gynecology like we did last year, just devoted to sex reassignment surgery and the process, the trials, the tribulations, the successes. And last year, we were lucky enough to have our first meeting with Dr. Susanna Nazarian, who's a surgeon at Jefferson University Hospital. And she was kind enough to offer to come back this year to speak with us again. And so our listeners who just loved hearing what she had to say could get a little bit more from her. We had such a great session last year, also because one of her super lovely patients joined us and gave his perspective on the surgery and the recovery, the risks, the benefits, the resources. And those were all really priceless to our listeners. And we had patients subsequently come into our office saying, thank you so much. I know it's important to talk about fibroids and periods and breast disease, but I'm really struggling with this. I'm really thinking of sex reassignment surgery, and I really didn't know how to start, where to go. And Dr. Nazarian and her patient really gave me hope and guidance and provided real good suggestions for even communities that I could join, social media communities or even in-person places I could go. So after that long intro, sorry, it's a funny time of day. It's a little sunny. I want to introduce Dr. Susanna Nazarian. Susanna, thank you so much for joining me, I guess from home. Did you make it home already? Hopefully.
Yes, thanks.
And Angelo Adrovo, I hope I'm saying your last name right, Angelo, is a patient of Dr. Nazarian's. And I'm going to let her really introduce him so that she can tell you a little bit about how the two of them came together. And then I hope Angelo will share his story with us. And my hope for tonight is that I want Dr. Nazarian to walk us all through the process, almost chapter by chapter, of the gender reassignment surgeries that she does, from initial consultation through what kind of processes get decided and how and what happens in what order, to planning and preparation before the procedure, to the procedure itself, even to post-procedure care, revisions, complications, risks, benefits, things like that. But I don't want it to be just a dry monologue. Obviously, we want your questions if you have questions for any of us. And I want Angelo to speak up, speak out, interrupt either of us if you want to, and share your comments and color what Dr. Nazarian says, so that we can really hear from you as well. So Sunan, I'm going to let you take it away, and if you would introduce Angelo and help us understand his amazing journey a little bit.
Thanks so much, Dr. Sophocles. It's really wonderful to be back, and I really appreciate the platform that you're providing for us, and I think so many other specialists and patients, I'm sure, outside of this particular realm of practice and the human experience. But so Angela is one of my wonderful patients. I count myself as very fortunate to get to meet a lot of incredible people. And I find my transgender and top surgery patients very inspirational. And I hope you don't see that I'm tearing up a smidge. But I think that it takes a lot of courage to express what we want in this world, and not everybody can do that. I think we all struggle with it in different ways, and I think the ability to articulate who you are and what you need and how you need to get it is really a gift that I see in my patients. And I'm inspired by, some people struggle and some people don't. Some people come in and they've had a really supportive family who's like, you're trans, we get it. Here, wear boy clothes and it's going to be easy for you. Other people come in with a lot of self-harm and a lot of, physical evidence of self-harm and a lot of psychiatric background and maybe use of substance. And it's all played out in front of me in clinic. And it's humbling because I don't come from an LGBTQ orientation myself. I am a cis woman married to a man, a cis man, and I have 2 kids. And I'm a parent. And I see my own personal family life with my 13-year-old daughter and my 7-year-old son and all of our own journey, which is messy and wonderful and mistake-ridden. And I think about what it would be like to have a trans child or to be a trans person. And it just, my life is simple in a lot of ways compared to these people that I get to meet. And I find it extremely inspirational to meet people like Angelo, who comes in with an extremely, and I love all my patients. I would just speak about Angelo for a second. He comes in with a very serene self-awareness. This is who I am. This is my beautiful girlfriend. Not kidding. Like, I wish you were here. Can you get her, please?
It's beautiful. I saw her.
They're stunning. Wow. Yeah, they are stunning. And
stunning couple.
This is who I am. And this is what I need to do to achieve better representation and stuff. I don't want to speak for Angela, but I guess just speaking from a surgical or doctoring perspective, I feel really privileged to get to hopefully, help people along in their life journey, and getting to sit in clinic and having people come in and being willing to share their stories with me is really privileged. And I try to start every visit with a new patient, just sitting down with a notepad and just being like, tell me who you are and tell me how we got where we are. And please, if you're able, share with me what's important to you and how you came to understand that this is who you are. And I don't think there's a lot of professions where people will speak so freely about all these things. And people tell me incredible things. And again, I get to be witness to it and hopefully help them along. But anyways, Angelo is a really special individual, and it's been a privilege to participate in part of his journey. And I guess I'll stop at that point. But anyhow, I'm very privileged and fortunate to get to meet people like Angelo and hopefully help them in their identity.
It is. You are very fortunate, because think about how, in an urgent care clinic, people are churning in with a urinary tract infection or a sprained wrist or something that's kind of generic. And the clinicians are sort of just trying to get them in and out quickly. And there's not, the privilege really that someone like you gets to really come into someone's life and to see what's behind their decision. Before Angelo talks, I have a question for you, Dr. Nazarian. How does what a patient says impact how you operate on them? Because isn't what you're doing just a recipe? Aren't you just following a recipe to remove this tissue and whatever? And of course, I'm being a little bit...
You're giving me a hook.
Yeah, I'm giving you a hook. But it helps. I think, first of all, I'm a surgeon too, and it's very easy for the public to think of surgeons as just people going to, chop off a tumor or take out your appendix or whatever. But we both know that as we get to know our patients better, we know what's behind their decision. And it helps me anyway to guide them perhaps towards the right surgery, whether it's the right amount or the right format or the right timing. How does what a patient like Angelo, how do your patients, what they tell you and what they bring to that decision, how does that impact what you do?
Well, yeah, I think that's a really important question, and actually a topical one. I think that I'm actually interested in launching, I was talking to somebody earlier today about launching a research project in a way to try to understand expectations and do kind of a satisfaction survey, in a sense of, there's a lot of different aspects of top surgery, and I think that you can prioritize certain aspects over other aspects. So, potentially somebody doesn't want to have big scars. Depending on your body habitus, in order to remove so the breast tissue can always be removed through a relatively small scar. For people who are like an A-cup breast, they could potentially have a peri-areolar approach, which is one way to affect top surgery. But then, you need to think about contour. And I think, speaking personally, sorry, Angela, I think Angela has a good contour, meaning that if you were to start with a large amount of breast volume, trying to understand how to get a 3-dimensional projection to a 2-dimensional projection and have it kind of wrap alongside of your chest without having extra skin, which can be called a dog ear sometimes, or extra soft tissue. It's actually kind of a geometric puzzle. And so trying to understand what's important to the patient. So dog ears are kind of a bane of all breast surgery, not top surgery exclusively, if you're doing a mastectomy, and how to kind of, prioritize what's important to a patient. So I had a patient I did recently, and I spent a lot of time doing my very best for this patient to, I'll speak, this is a self-critique, but sometimes also in larger human beings, there is extra adipose tissue on the medial, on the inside aspect. And so the breast tissue ends at the sternum. And so if you're like literally just doing the top surgery, you're going to take off the tissue that, goes to the sternum, but there can also be some extra adipose fat cells and soft tissue that goes beyond that. And, the patient says, I have a little lump in the middle. It's not, honestly, it's very small, but he said, I would like to have you just make a single incision across my entire chest. Like, we're talking about possibly going back for revision, as you alluded to. And, I think trying to understand kind of what is important to each individual is really important. So,
right. So amount of scar tissue.
That wouldn't have been my first thought, that like a single scar across the entire chest would have been acceptable to somebody. I realize that's how some surgeries are accomplished. But yeah, there's trade-offs in all aspects, whether, et cetera. But,
so you interview them, and when someone wants top surgery, I guess you talk to them about different approaches. You talk to them about the risks of like this dog ear, which is sort of a extra tissue off to the side, off laterally. Is that kind of, can you explain what a dog ear is or looks like?
Yeah. So, the anatomic limits of breast tissue. So, the first job, I think, in my mind, I personally approach top surgery almost always as complete removal of breast tissue. I think that's another question, though. Some people want to have more of, here, I'll write this word down because it's not a real word, but I've had a couple people say they want a moob.
A moob.
Which, is like I guess they say a man boob. So in that case, we would be removing less breast tissue and making more of a kind of gender neutral chest. Okay. But in my mind, if you remove all the breast tissue, then you're A, crossing the line from female to male, and B, you are also enabling the patient to be free of concern for breast disease in the future, and you're freeing them from mammograms, which is I think going in as a male to a mammogram, I think might be an uncomfortable situation.
Right, it's a yearly reminder that you're a man in a female setting, in a woman's setting. The patients who come for their pap smears have the same issue. They hate it. They hate coming and having to have a pap smear because it's just a reminder that you think you've done all this work, but you're still here, and so it's tough. It's really tough. So when you say remove all the breast tissue, are we talking about just fat, or is there muscle removed? Are there lymph nodes removed? Can you tell listeners?
No, yeah, sorry, to get back to the kind of the anatomic borders of the classical anatomic borders of the breast, extend up to the clavicle potentially, which is the collarbone, laterally out to the serratus muscle. But if you were to take off your clothes and look in the mirror, you can usually see kind of obviously where the breast ends. Medially, like towards the middle, as I was saying, to the the border of your sternum, your breastbone here. I guess we don't have to call it a breastbone. We'll call it a sternum.
Yes.
And then inferiorly to lower down to where, you know, your bra runs, like that underwire if you had worn a bra in the past. So that's, I mean, that's the breast tissue. That's the first part of the operation in my mind, is just getting that out. And that can be done very expeditiously. You know, that's the easy part for me of the operation, is just to remove that, and then we're done. The next part is the arch part, and frankly, it takes me a lot longer. And that's making measurements, lining up. So I just get that out through, you know, an easy incision, which is easy to remove the breast tissue. Then comes the more challenging part, where, you know, I tell the OR staff, okay, turn off the music. I'm really focusing here, and we are going to, you know, make a lot of measurements. We are going to try to get the scars lined up. We are going to take off additional tissue, which is like soft tissue and fat, like skin and fat, basically, and try to make this, you know, again, the contour is primarily important. And dog ears, basically, if you, I mean, some of us are very thin, like Angelo and Dr. Sophocles, but most of us have a little bit of, yeah, exactly. Sure. Most of us have a little bit of extra tissue on the side. So if you like lift up your armpit and you look down here, that's not breast tissue. That's
extra
love.
Yeah.
But what happens even in cis women who are getting mastectomies for breast cancer reasons, that becomes much more that area becomes much more obvious and noticeable after the breast tissue is removed. And women will come in, like 70-year-old women with breast cancer will come in and say, that didn't used to be there.
Right.
And I'll say,
they see it now.
Sorry, it's always been there. I did my best. Yeah, I took all this extra stuff, and you still see a little lump, and we can revise that. But that's a challenge in top surgery.
Got it. That makes sense. Is you know, cosmesis, right? That cosmetically it looks how the patient is imagining it will look. And that's why you have to take the time to say, what do you want? And if someone wants to have not just a sort of gender neutral look, but the ability to really have pecs, you know, a really defined pec, can they do that? Is that something?
Yeah, well, I mean, I'm not going to ask Angelo to do anything that he doesn't feel comfortable with, but
that was something that I remember asking for at some point. I remember in the beginning when I first came to you, I didn't really have an idea of what I wanted my chest to look like, which I also felt like contrasted the kind of like norm of top surgery that I've seen in the media. People usually, at least from what I've seen, have like a very clear idea of what they think, you know, it's going to look like or what they hope for. And I didn't. And then I went from using binders to using trans tape. And that kind of allows you to have more chest exposure. But like your nipples are still covered because the tape is kind of like, you're using the tape. It's kind of like an adhesive tape that you can keep on for an extended period of time that allows you to contour your chest on your own. So that kind of gave like a kind of like a pecs kind of look. And I realized that I liked that. And I remember I messaged Dr. Nazarian, like, I don't know, maybe a month or so before the surgery that I had a clear idea of what I was looking for. And so
the trans tape helped you to see, like with your clothes on, kind of a contour or a look that felt
yeah, even with my clothes off, it helped me to have an idea because that's where I felt the limit of the binder was.
Yeah.
That I had an idea of, you know, seeing myself in the way that I see myself within my head, with the binder on, with clothes on. Then you take the clothes off and the binder is still there, you know.
Right.
So with
is
the tape,
trans tape very I help me understand trans tape.
so I can actually grab it. It's right here.
Thanks, Angela.
Sure.
it's in the closet.
Dirty laundry, new outfit.
So this is what trans tape looks like.
Okay.
There are a couple different colors.
Wow. Wait, can you show that again? That's thicker than I imagined.
Yeah, here, so
Thanks,
I don't
Angela.
have any example strips. Sure. Now there's this color, and which you can see like is kind of darker than my complexion, even though I have a tan. a little tan. And then there's one that's a little bit lighter. Truthfully, I think that it works really well for white people because the color that they have for the brand matches skin tone much better and really gives this kind of like invisible look. And for a lot of people, I think that trans tape is a long-term solution for them if they're not sure about top surgery
Yeah.
because it works. But for me, just because it one didn't really give that kind of like invisible look, and two, it's also um, it's also really not the safest option for your skin because it is an adhesive and it's a strong adhesive, and so it lasts for I think the recommended date is like around mm, like 7 days.
Wow.
Yeah, so that's the good part. You can shower with it, you could
Sure.
swim with it, but because it's so strong when it comes to take it off, it's
Yeah.
still really stuck to your skin.
Right.
And I would get blisters, and then you have to wait an even longer time before putting it on.
Sure.
And I still have some of the tan lines from when I first came to Dr. Nazarian with the trans tape on. So it's another version of binding. It's a really good alternative to start, but it's also ultimately why I was ready for top surgery because I was like, both of these methods are damaging my body. You know, like binding, I was feeling the pain in like breast tissue, and I was feeling the constriction in my breathing. You really can only wear a binder for like I think a maximum of 8 hours, and you're supposed to take breaks. It gets really hot in the summer with them as well. So both of them had their limits,
Yeah.
and it was really taking up a lot of time. Just I was planning my weeks and my days around binding schedules.
Sure.
Even my work days, the days where I was using trans tape, you have to take a 2-day break. And I even had my work scheduled around my binding. So
Wow. That's
yeah.
amazing, Angela.
And
Wow.
if
Thank you.
you get blisters or irritation from the trans tape, you're going to take at least those 2 days because you've got to let that heal.
You have to take even longer because you can't put an adhesive on top of an open wound. So you
Yeah.
have to let the wound completely heal, which can take like a week or so. So then you're putting a binder over that, which still isn't really letting the skin breathe. So it was a lot of discomfort, a
Yeah.
lot of discomfort. So yeah. Hmm.
And I wonder, and just do you mind sharing the cost of the trans tape and of the binders? Is that prohibitive?
Sure.
Or it's very
Yeah.
cost?
So the binders I got from a brand that is called, I'll put it in the chat because it's just a bunch of letters. Um, it's called GC2B. Right. That's the name of the binder brand.
Okay,
They,
we'll put that up on the.
uh,
See.
the cost for that, I think, was maybe around, I'm gonna say like $30 to $40. It wasn't as expensive as I thought that they would be. I mean, it's definitely not like it depends on what your cost range is, you know. But I felt like they were pretty affordable, and I have about 3 different types that I don't wear now,
Mhm.
but that was an option that I used for a while. With binding, it's really important to have the size that fits you,
Mhm.
because it either doesn't it's too big and so it doesn't really constrict well, or it's too small and then it really damages your body. And a lot of people will get their first binder, it maybe be too small because they were excited about it and really wanted it to be as constricting as they hoped it would be, and
Sure.
it's too small, and it shouldn't hurt when you put it on. Like, granted, it did take some getting used to, so I was like, is this too small? Is it hurting, or is it just I'm not used to it? And I realized after like maybe wearing it around for a day that it was the right size.
Mhm.
Um, but a lot of people wear a binder that's too small for them, and that can be really damaging because it damages your ribs, and it is pressing on that breast tissue, and after a while that gets really sore, and you are supposed to massage that out too. But a lot of people who are trans and who bind have dysphoria with their chest anyway, which is why they're binding. So then asking them to massage that area and take care of it is difficult. So there's a lot wrapped up into that.
Can you tell me a little bit more about you? Are you massaging after you take the binder off? Because is it because the skin, the tissue's been so compressed, and it's massaging just to kind of normalize it or get some blood flow back there? Is that why
I
that's recommended?
I
Or
I think that it would be recommended to kind of like just break up all the tension in that area that's built up.
mm-hmm.
Um, and yeah, to just give your body the signals to like release and relax.
Yeah. Did
Because
you? Oh, I'm sorry.
no, go ahead.
Did you, after the surgery, need to use a binder? Or is that part of what Dr. Nazarian asked you to kind of, or not necessary?
It was a little bit tricky because I had two surgeons, so it was Dr. Nazarian and then Dr. Abdullahi,
Mhm.
and I kind of got different instructions, and then eventually just went with Dr. Nazarian anyway. And but some people, and I've noticed with top surgery after seeing many people's stories that it really, like, the advice that you get, the instructions to follow are very specific to your specific top surgery, and you have to like follow your surgeon's instructions and not everyone else's. A lot of people out of top surgery do have some sort of constricting vest, whether it's like a special one their doctor gave them, or just they just say, hey, just use a binder that you had while they're healing, so
Mhm.
that, like, I guess so the fluid doesn't build up and keep the swelling down. So I did wear a binder for maybe a short period of time afterwards, just to like help keep things compact and together.
Mhm.
But after then, I haven't used them. I'm actually looking for a way to donate them to someone else, since I don't need them anymore.
I'll bet we could find a resource. First of all, I'm sure eBay has a market for used binders, but that aside, I bet we could find something for
Yeah,
donation. That'd be
absolutely.
really neat. You'd feel so good
That'd
passing it.
be great. Yes, I have two size smalls, and the other one I believe is a size medium. And also the trans tape, to answer how much it costs. It's not fresh in my mind, but I think that's maybe around like $15 to $30 as well. They
Mhm.
give you an oil solve to remove the tape with,
Yeah.
but it's filled with a lot of essential oils, which are purposeful, but I have really sensitive skin. And so I just use coconut oil,
Okay.
and that worked a lot better for me. And I know that a lot of other people remove it that way as well.
Thank you so much. These are such important tips. These are called real life, real world stuff. People
Sure.
are out there like, should I buy it? Well, Angela says I should, but I don't,
Yeah.
they're the kind of things that are priceless, priceless for people to understand. Um, Dr. Nazarian, would you mind walking us through a little bit when a patient comes to you? Does your clinic have a process or a protocol where they say, okay, you're interested in this, we need a mammogram, or we need these tests? Are there pre-op tests, or is there psychological counseling? Is there a battery of tests, or is it just talking and scheduling the surgery? What's involved?
Yeah, well, you know, first off, as I was saying, it's trying to get to know the individual and trying to understand, where they're coming from, and understanding, their life, and also, their clarity of purpose. There have been a few patients that I haven't felt comfortable with, and I hope that they got cared for by other surgeons. But there's some people who, will message me and say, I want this. And then they'll message me a few weeks later and saying, I mean, just not just different types of things. Like, I want to have a longer arms and a smaller torso, or actually I'm a woman and I want to be a woman, and just feeling like I feel like, well, top surgery is undoable. It's not super undoable in the sense of you can go and you can get breast implants and go back to be,
Yeah.
female presentation. But I really want to be sure that I'm doing right by the person. And I think that's the number one thing is that, some people, there is a lot of mental health issues. And I recognize that there's a lot of good reasons for people to have mental health and psychiatric struggles. I mean, if you've grown up in a situation where you didn't feel like your identity was acknowledged or recognized or valued, and you proceeded on to self-harm and your family kicked you out and you are brilliant, yet you couldn't complete high school for these reasons, all this stuff is super complicated. And I respect it and I get it. But there are some people who I just don't feel like we're in the right safe space to proceed right now. And that doesn't mean forever. But that may just mean, right now we're not in a safe space in terms of taking care of ourselves after surgery.
Got it.
And feeling clarity of purpose. And I sometimes I'm caught because I feel like I think that this would help this person in the fundamental sense, but can we get through just kind of the self-care necessary and things like that? So it's honestly sometimes a struggle for me because I want to be helpful, but at the same time I want to. And maybe you have the same thing in your practice, but
yeah, you don't want
you want
to
be a guardian of health, and it's complicated. And I feel like sometimes I'm making decisions which I shouldn't be making, but I do the best I can with talking to therapists and psychiatrists and things like that to, at least in the short term, try to make the right call.
Yep.
So that can be a big thing.
Understood.
Not for Angelo. I think, as I said, Angelo is very centered in himself, and that's a blessing for him and for the people he lives with and loves. But, the next step is just kind of basic, like surgery 101. Like, do you have any pre-op conditions that need to be dealt with? Yeah, a lot of my patients are young, and they're a very different patient population than my breast cancer patients, who are often in their 60s and 70s and sometimes 80s. But just basic like EKG, have you had labs, like that sort of stuff. In terms of breast cancer screening and imaging, I've shifted somewhat with that. And initially, I was very fearful of accidentally encountering a breast tumor.
Yeah.
When the breast tissue is removed, we send it to pathology for all patients. And now I'm being more selective, and I can't remember what I asked Angela to do, but I'm being more selective with that. So if a patient has a strong family history of breast cancer, just as would be recommended for breast reduction, I say, let's say you're 20 and your mom got cancer at 35, then maybe we should get a mammogram, at least an ultrasound, 10 years younger. Okay. So not for everybody, but trying to be, selective about it. And just to the point we said earlier, the idea of a mammogram or an ultrasound for some people is very off-putting. And even, as he was saying, the physical exam, like I need to touch you. And I realize for some people that's extremely uncomfortable. And I try to be respectful of that. But another important aspect is just getting insurance clearance. And this is not covered by all insurances, unfortunately. So it ranges from completely covered or covered with some copay to not covered. I have a vet, United States military veteran who has VA insurance, and it kills me that their surgery can't be covered because they have VA insurance. And there's nothing that I feel like I can do in my immediate power to reverse that. There are some people whose gender affirming surgery is only kicks in, their coverage just kicks in at age 18, which, for someone who's 16 or 15 and they're really struggling, like I think those 2 years are really critical to their development and health. And I think to put them into a situation, Angela's a mature individual, but like he was able to like coordinate his work schedule around binding. I mean, that's for me, like I didn't even think about that. But like,
right.
To put a kid in high school and having them live in a body that they don't feel good in and then, having to wait for that. And then, most people don't have a lot of just cash in the bank, but I have a lot of patients who don't come from rich families and their parents are like, we're going to pay out of pocket. And I haven't yet really accepted that, frankly. I just don't feel great about that. I had a patient who lives in a bus he doesn't have running water, and he told me he wants to pay cash. And I understand how critical this is for him, but I just said, we need to find you some insurance. Like, I don't want to take your money.
Yeah.
This, and we have to figure out a way to make this work. So anyhow, getting back to the whole like checklist, we need a letter from a mental health professional attesting to the fact that this is an enduring condition. This is not a whim, you know, and that then goes to the insurance company to achieve clearance, so that the surgery can hopefully be paid for.
I know I felt really blessed with that too, because kind of like the way that my journey started was I was already out to my family as non-binary, and now I identify still as like a trans male and non-binary. But I was working with a coworker, and I was currently looking for a different doctor to go to because my primary doctor was a women's health center, and just coming more into myself, I really stood out there. I really didn't feel comfortable. And also just for general checkups, I really felt like it was almost like they didn't know that queer people existed. Like I remember, I think my last appointment there was actually just for maybe like a standard STI testing. And they were asking me about like partners and stuff. And their correlation between like whether sex was safe or not was whether or not you used a condom. And I'm like, there's a lot more things that go into that, especially within like the queer community, and that's not really what I'm interested in.
It's a little narrow, right?
Yeah. So he recommended this practice. It's Jefferson, and I hadn't ever gone to Jefferson before. And it's specifically the LGBT affirming practice in Haddonfield, New Jersey.
Wonderful.
It's absolutely amazing. It's absolutely amazing. It was so easy to get an appointment. I think it's like a relatively like new office space, so they're still building patients. They had little trans and pan flags like all over the office. Staff is amazing. And kind of, I went there not really knowing I was trans yet, but I did have questions about hormone replacement therapy. And so I went for my first appointment with my doctor just to ask those questions. And he was like, you know what? Like, let's just do all the standard testing, like the EKGs and the blood tests, just in case you decide to start. And we'll just kind of put you on the path just in case. And that kind of, yeah, it solidified everything for me. Everything was already en route. And I also had the appointment made with the I think he's called a behavioral psychologist for who specializes in like gender identity to have the letter for top surgery.
Fantastic. Is he Jefferson affiliated? I said
yes.
Jefferson.
Yes. So it's actually all within one Jefferson office. Like all of those doctors are in that one practice in Haddonfield, which is absolutely amazing. And
this practice was started I'm sorry to interrupt. It was started like 2 Januaries ago, so like 18 months ago.
Yeah.
And it's in a freestanding building, as Angela is saying, in Haddonfield, New Jersey, which I don't know, it's 30 minutes from Princeton or 45 minutes from Princeton.
Yeah. Listen, to get the right place.
They have people coming from all over. And what's amazing is that they are really busy now. And
wow, that's great.
And what it means to me is that all these people probably weren't getting care.
No.
Or they were getting care in a place that they didn't feel good about. But I mean, there's just so many patients there now, and it's a great practice.
It's amazing.
I mean, all the providers are, I think, of the LGBTQ community. I went out and partied with them one night.
That's great.
It was awesome. I was like, hi, I'll try to be as cool as you. And I'm actually going to start office hours there because, currently, it's great. Like, I've been seeing patients like Angelo in my breast cancer practice, and my staff has been fantastic, and we've been through a lot of growth, and they've been really affirming, and I really think it's super. But I also think that being in an even more safe space
Specialized. Yeah.
will be helpful, I hope. So I'm super all in the Haddonfield, New Jersey, Jefferson practice, and I think it's a great thing. So.
And they have a network for all the other doctors too. Like I didn't really just have to find a primary and stop there. They had the references for all the other doctors. Like that's how I got connected to you, because they said, okay, like, well, and they make the appointment. See, like it. So I felt really blessed because I kind of just had to make the appointment with the new center, and my first appointment with the Jefferson Care in Hanfield. And since then, everything has kind of been made easy for me. It's kind of like, yeah, you're trans, okay, we get that, cool. Let's get you everything that you could possibly need. And I think that for me now, and probably for a lot of other patients who are not binary or not cis, that even if the experience within the office, like whatever is being done, may be uncomfortable, I think it makes such a big difference that the space that it's being done in and the people who it are being done by feel like a safe space and feel like they genuinely care, because you can tell the difference when they're just not even seeing you and they're just kind of, you're just the next patient in the door, and they're just getting things like done off the checklist and that's it, versus they see you as a person. They really want to get to understand you as an individual and get you the care that you need and make you feel safe. And I remember that those are really my first experiences with that as a patient, and even just like as a young adult, and I remember when I first had my consultation with you, Dr. Nazarian, me and Niambi were so surprised that your first questions were just kind of like, what are you like passionate about? Like, what are you into? Like, what do you do in your like daily life? And I was like, wow, like you care about these types of things. Like doctors don't usually ask that stuff.
Right.
So,
Usually, what can I do for you? Where does it hurt?
yeah. So I've just always felt safe and felt seen, and I'm very grateful. Very grateful. I feel like Dr. Nazarian goes above and beyond.
I don't doubt it.
Yeah,
So, this isn't about me, it's about you guys, but I will let you know, Angela. So I'm a gynecologist and I'm a pelvic surgeon, but I'm also a sex therapist, which is a kind of odd
that's great.
combination. But I did that because I was so poorly trained in sexual issues. We spent all our time learning how to deliver babies and do surgery and cancer and infertility and all these important things. But as I became, I had more and more patients who were menopausal, and more of them had sexual issues related to menopause. And then more of my younger patients started having issues related to sex. And then when more people started becoming comfortable discussing some of their gender identity issues, I felt horribly under trained and ill prepared to talk to them. I didn't have answers. So I got certified, which was fine. That was done. But what I realized in the process is that so many of my peers, so many OBGYNs in America do not get any training in matters of gender identity, sexual identity, non-binary patients. These are not new terms or topics, but we are still not trained. And I'm not young, but my younger cohort are still not being trained. And on top of that, even the few who are trained, many of them don't feel comfortable because it was never discussed in their own family. Or they're a cis male or cis female, and they just don't feel comfortable. So it's so few physicians, even so few OBGYNs that feel comfortable, that there's no doubt in my mind that this is underdiagnosed, not that it's a diagnosis, under discussed. That's the word I'm trying to say.
Yeah.
In fact, since I put my foot in my mouth and said underdiagnosed, I'll tell you a really annoying, embarrassing story. A trans woman came into my practice and she was just so lovely. And I had a lovely talk with her, and same thing. I said, "Tell me about yourself and your past, and how did you come to be at my practice?" And she said, "Dr. Sophocles, this is the 6th OBGYN practice I've been to. The other 5 asked me to leave because they said they're not comfortable with me in their office, and they don't want the other patients to be uncomfortable," which you can imagine how that made her feel. And she said one of the practices, the doctor said to her, "So, what tell me something about yourself." And she said, "Well, I'm a trans woman." And he said, "Okay, I'll put that under disease." And he listed it as a disease. No one wants to think of themselves and their identity as a disease. So I think we have so far to go as a group of physicians, nurse practitioners, PAs, and, I hope that as much as I trust Dr. Nazarian to not be like that, I hope our training programs can embrace some of the way Jefferson is doing things and Dr. Nazarian is doing things, and that people like Dr. Nazarian can train the next generation of clinicians to have sensitivity and compassion. And um, the big word that I use when I train physicians to talk about sex is permission. I mean, I should think more about what you said, kindness and making a patient feel safe. But I want patients to feel they have permission to share who they identify as and how they identify, and permission to share their life and their view of themselves. So you're giving me a lot of ideas of how maybe we can do this better, so that you don't have to just have Haddonfield.
Right.
More
Yeah.
practices will have, whether it's trans or LGBTQ flags or little notices, or even in their intake information, right? I think of the questions so many doctors' offices ask that are really questions created for a cis male or a cis female.
Yes.
Just, those are the questions we learned.
Yeah, I think that it's a lot wrapped up into it, because for the first thing is that people don't realize that it's not inclusive because they are not a part of that minority.
Right.
And so the people who are hyper aware of the fact that it's not inclusive are the people who it doesn't include. And it
Right.
also often doesn't
So obvious.
feel like a safe space to communicate that, because I think that there is a lot of progression that's going on around the world, and in America, as far as being open towards non-binary people and gender non-conforming people and transness. It's still a whole huge, political, even though it shouldn't be political, debate as to whether we should even be allowed to exist. So I think that that makes it even harder for that to be addressed in medical spaces, because then it's deciding that that's a yes to that question. And I think that a lot of people just aren't ready for that. And I think that the reason why a lot of people aren't is because they don't even really know what that means. Like, they don't really know that the science has already been proven that it's biological, and they don't understand. And then I think there's also the medical history behind it that kind of makes it also seem like it makes things confusing, because I know that in some places it's still very hard to get gender affirming surgery, or even hormone replacement therapy,
Sure.
because you have to have proof that you're trans enough in order for you to get access to those things. And that means like maybe living under a certain name for a period of time, or whatever things. And there really isn't an example of what trans looks like, or what non-conforming looks like, or what non-binary looks like. And I think that in a way that was kind of in the past, so that when it goes to courts and stuff like that, they can say no and have a reason behind it. And so now, even with needing the doctor's approval in order to go ahead and say, like, yeah, this person is sound of mind, they have to, they can go with it. It still has to be the diagnosis, even though we know that it's not a mental disorder, but it still has to be classified as I think it's like gender dysphoria disorder.
Right.
And
Right.
Like that's something that,
That
like, if I have to
code.
go under those titles, that's something that I could say that I
Yeah,
have, because like medically I have, that's in my file and had to be there so that I could get, affirmative surgery. So I think that for people who are just less educated and less aware, it's confusing to understand how there's nothing wrong with us, but and we need to be treated as such medically, where there's also still in the same medical world that they're learning about says that no, yeah, it's a disorder and still is presently today. So I think that that can be confusing.
yeah, yeah. I'm working on a book about sexuality in middle age and what happens to um, sex lives of couples in middle age. And so I've had to research a lot of the history of sexual dysfunction in women and in men. And
Mhm.
it's super interesting that male dysfunction, used to be called impotence, and it was like a disease and it was shameful. There was so much shame. And then once Viagra was invented, Pfizer hired experts to change the name to erectile dysfunction. And we took it from a shameful disease to a common thing. Most people have it. Just go to your doctor, get a pill. You'll be cool. You'll be more than cool. You'll be a rock star. And they flipped it from a negative disease to a positive thing. And of course, Viagra sold $1 billion worth in the first year. But the history talks about the deep shame of when it was called impotence. You're impotent, you're weak, you're not masculine. And the whole played on that whole stereotypical masculinity has to be strong and virile. And the ultimate symbol of that is an erect penis. I mean, there's so much psychology in what
Yeah.
we call disease or not disease, right? And for females, of course, people have thought women who had sexual issues must be crazy. I mean, women aren't even supposed to have sexual issues. We're not even supposed to talk about sex. So our whole medical history related to anything sexual slash gender is already a strange tightrope we're walking between physiological or biological diagnosis or disease and mental health, or this is all in your head, or, and so I think, to be honest, I think the trouble and the tragedy this country has with the concept of transgender people and transgender surgery comes from a fear of something different that they don't understand, and from our own whole almost prudish puritanical origins that now are getting pushed out of that comfort zone, because the cis heterosexual couples, what's always been called the couple in America, and challenge to that, when you're pushing outside that norm, even clinicians who should be trained better, should know better, struggle with what they bring to the table. I mean, it's a shame, Angelo, but I hope, that your generation will see, well, political acceptance of this and popular acceptance of this, so that
That's already coming up as well too. I think it's really easy to focus on the negative because that's also what's unfortunately gains the most media traction, which
yeah,
is why it's important to be mindful of who's broadcasting it. But I think places like The Office in Haddonfield and places like that just show that the world is being more progressive,
thank
and
goodness.
there are people who get it, and there are practices established that get it. There
Yeah.
there are the right doctors like Dr. Nazarian out there. There are the right spaces, and it's really just a matter of who we're talking to and just talking about it
Yeah.
more.
Do you have any suggestions for people watching who might be earlier than you, just thinking about their own identity and thinking about this and maybe looking for a community,
Hmm.
whether it's in person meetings or group meetings, or a therapist that you think is just super, super
Yeah.
progressive, or even social media groups? I mean, if you have any, boy, I'd really appreciate it.
Well, what I can put here, I'm putting in the chat right
I see
now.
you typing with one finger.
Uh, this
You
is
aced your typing class in high school.
That's right.
That's the first one. That's Soul Speakings. That's my Instagram, and
Okay.
it's a public page, so people are like, if anyone reaches out, I'm totally open to that. Excuse me.
Awesome. Thank
And
you.
there's also, you're welcome. There's also another page. It's called Folks Health. I'll put that in the chat too.
By the way, you type faster with one finger than I do with 10, so I
Really?
no place to.
uh, there's that Folks Health is kind of it's generally new,
Is
but
that
they
it,
put out,
or where is that? What is
that's
that?
on Instagram.
That's
Yeah,
it.
they're all on Instagram. They're kind of like, I think, and this is kind of going to be like poorly described because I truthfully don't know that much about them, but I do follow their page. They do put a lot of information out about like gender affirming healthcare, and they do have options for people who may not have insurance, like general insurance. I think they're building to become like a new type of insurance specifically geared towards trans and non-binary people.
Cool.
So
Wow.
that's great. And I think that, excuse me, I learned a lot on my own from watching movies. The first movie that I watched is actually a documentary, but it's really interesting. And it's hosted by Laverne Cox. And it's called Disclosure. I'll put that in the chat too. It is kind of,
You keep close.
it's kind of heavy because it talks about the history of like trans and non-binary people in cinema, and it talks about how that is really how a lot of us gather our information about different gender identities, and really kind of the only space that we do, because like if we're not talking to other people who are, and we don't know anybody else that is, then all that we're seeing is what we see on TV and
Yeah.
in movies. And a lot of the time that's written by just like 6-year-old cis white men who have absolutely no clue, you know,
Yeah.
and have their own prejudices. And let me drink some water.
While you're doing that, I'll share that as you're talking, I can't help but think of the similarities a little bit between this and the fight nationally right now to maintain abortion rights, right? And that the decisions of women's reproductive health in an abortion sense is getting made by a bunch of 60 to 70-year-old, mostly
Yeah.
white males, mostly males, not completely, but such a small group of people, perhaps none of whom have ever been involved or needed to have an abortion or been, but I was marching in Washington a couple of weeks ago with a whole lot of people, and so many of the people marching were 75-year-old men and women with posters saying, "Gosh, I did this march 50 years ago. Why are we still marching about this?" So I certainly, and again, I think some of it comes from radicalized media that portrays abortion as a scary, dangerous, murderous thing. And I don't want to make this about that, but so much is fear when people don't know
Yeah.
what it is, and they imagine something worse than it is, or they imagine something that doesn't belong in their society, and it just comes from ignorance and naivete. So I do think education is critical, and discussion and disclosure is critical. I like
That's a reason that I really enjoy getting to know my patients, is because there's a lot of nonsense in the media, and I just wish that people who put out these opinions and try to change rulings and try to restrict access to healthcare, and I mean all the stuff that's hanging that we're well aware of. I wish they had the opportunity to talk to somebody like Angelo or my other patients, because it's so Angelo's a human being, and we can't discredit who he is, and or dehumanize or anything else. And it's just that's why I really, enjoy getting to know my patients, because I think it's helpful to propel us forward.
Definitely.
Yeah.
You know what, Angelo? I'm going to say just one thing, that before you even opened your mouth, when we were saying hi and welcome, you have the most exquisite smile, and it's so natural, and you can't even help it. I don't think
you.
you tried. And as soon as I saw that gorgeous smile, my dad was a dentist, so that's probably why I noticed these things. I I thought exactly what you just said, Dr. Nazarian. I thought Angelo is a beautiful human being.
Thank
And
you.
I didn't, I didn't say a beautiful man, a beautiful woman, a beautiful they, but just a beautiful human being. And just like, Hillary Clinton said, women's rights are human rights. And
Yeah.
of course, patients who want abortions they want dignity. They want to be treated as a human, not as a criminal. And I think trans rights are actually human rights. I know that's
That
corny, but I feel like these are human rights. The right to be able to be the person you want to be, that is so basic. But we also live in a country that has for-profit healthcare in general. We don't have universal healthcare, and I moved here from a country where there was universal health care. And so I really appreciate, having left that, how hard it is in this country. We Dr. Nazarian and I, cannot take for granted, and we don't, that everyone will have access to health care at all, much less health care for gender reassignment surgery. So we've got a ways to go. We
I
know
think
that.
that even abortion rights are trans rights, and that's come up on a lot of the trans accounts that I follow. That abortion, debate is really is really forward in the trans discussion as well, just because there are a lot of trans people, men and women, who pregnancy is a part of the conversation. And there are plenty of identified trans men who, don't necessarily want to get rid of their reproductive system. And I think that's also like,
Don't want to be pregnant, and don't
or
forget,
that they do.
or they do. Okay.
And so it's just kind of like that whole debate around it.
Yeah.
As saying, like, you know, um, it goes so much further than just women's bodies, and I
Sure.
think that they, even the people who are running the conversation of saying that, like, oh, like they should be illegal and stuff like that, they're I don't really know who they're thinking about because there's so many other people you could think about and say, oh yeah, no, it makes a lot of sense why they exist, and
Yeah.
that there's a lot of things that exist like that. Um, yeah.
Well, I don't mean to bring this to a downer note, but I do a lot of, I get, unfortunately, I have to see a lot of my patients who are victims of assault, sexual assault, and unwanted non-consensual sex. So I see unplanned and undesired pregnancies, or other sequelae of assault. And the LGBTQ patients, including some of my trans patients, are victims of assault disproportionately. And again, I'm sorry to bring it down to a not pleasant topic, but that's what I started thinking of when we were talking about pregnancy. Is I thought, if you want to identify as male and you are assaulted and made pregnant, this is probably even worse than having to go get a mammogram. This is really, really painful. And so to take away the ability to have a pregnancy termination from someone who doesn't want to go through a pregnancy and go through a very stereotypically female 9-month process is brutal. That's a brutal thing to ask of someone. And so, as you said, there's all different sides to this story. And that's why a talk like this tonight, could go in so many ways. And I'm glad we have Dr. Nazarian here to help us understand the process. And thank you so much, Angelo, too, for being a great dynamic duo to help. And as a gynecologist, I have my own sort of peripheral edge to this that I see, but there's just so much that that people who watch gynecology ask me about, and no one could do a better job than you two at helping clarify, educate, and really give a human and personal note to this. So I thank you so much. Are there any other comments you'd like to make, or any other resources, or any other points that, we've covered so much tonight, but I don't mind if you have other stuff,
Angela, we haven't talked about testosterone, I don't think, at all.
Oh, sure.
Is that something you want to speak on?
Yeah, absolutely. There's really a lot of different things I could touch on with that. I originally started testosterone not wanting to do needles. I had a fear of needles ever since I was a kid. And when I was open and realizing that I wanted hormone replacement therapy, and what they called it at the Jefferson office was, I think, masculinization hormone treatment. So that was another term that I didn't know that existed for it that I liked.
Mm-hmm.
But so they started me with patches, and I have a bunch of those in my closet as well.
You're at an emporium. The Angela Emporium for
next time you're on, we're just going to open that closet.
Yeah.
Are they called Intrinsa? Are they called Intrinsa? Is that the brand that testosterone patch that?
No, actually, they're right there. So let me just.
Yeah, sure. Well, this is a big problem in sexual medicine and GYN is there is no commercially available testosterone approved for women for sexual dysfunction. So those of us who are sexual medicine experts have to go underground and get it compounded from compounding pharmacies. Because nobody will invest the money to make a testosterone product that will be studied on women or FDA approved for female sexual function. It's just not considered important enough, which is frustrating.
So the dose for that, I assume, is fractions.
Tiny. It's 1/10 of probably Angela's dose. It's 1/10 of the dose many men use prescribed by their urologist. 1/10. But I'm sorry, Angela. I don't want to take from.
No, sure. You're good. So the name of these patches are called Angioderm. It's 2 milligrams per day. And the way it's just like a little pouch like this. Perfect. You get a 30-month supply. And this was not fully covered by insurance. They covered a good chunk of it though. I think like maybe individually it was like $200 and it was $40 a month instead, which is still a lot.
For a box.
Yeah, it's still a lot that adds up.
As a week or?
So it's actually every day. So you would, and I mean, I can't use these now anyway, so I can show you what it looks like.
Thank you.
Sure. So it's a little patch like this. And in this little bubble part is where the testosterone is. And then this is the adhesive. So you would kind of peel like this plastic part off, and then that exposes you to like the testosterone. And then you would just place that on a space. And you would do that pretty much at the same time every day. And then that throughout the day like releases the medicine to that area, and then you take it off and then you put on another one, and there isn't really a day that you take a break. The good thing about the patches is that it's a really consistent amount of testosterone on a daily basis, whereas with needles it's like, there's all the little variations that can be with that, like between there being a bubble in the syringe or like a little bit less 1 week, a little bit less. Yeah. So I really like the patches to start because I didn't have to use a needle. I didn't really mind that like it's exposed. And so, yeah. But the thing about this is, again, I have sensitive skin. And after about 3 weeks, I developed an allergic reaction. That was really, really bad. It was like I was so fine with these for the first 3 weeks. And then like by the day I put on the final one, my skin just said no. And it was really itchy. It was really inflamed. and I actually have, I don't know if you can see it, a scar
Yeah.
from the patch. It's gotten a lot lighter, but I had them in a couple areas on my body. And every place that I had put the patch developed that same allergic reaction. So even though I didn't have a reaction until um, maybe it was the second week, so like that 14th day, I had already put it in 14 different places on my body, and every space had a
Oh,
reaction. So at that
uh,
point, I was like, I don't care what version you guys put me on. Just give me something different because these patches are not working. And they do work for a lot of people. They work for a lot of people.
yeah,
They wanted to give me the gel next, which
right.
is another version. It's a really common version. I just didn't want to use the gel because I didn't want something topical again after knowing my skin is sensitive. And also, you have to like wait for it to dry, and I was like, I don't really want to have to worry about like not having contact with people, especially like being in a relationship, um, in between that drying time. And I heard like the gel works really well for a lot of people too. So I encourage everyone to just like do their research about what options might be best for them. But now I'm on the needles, and it's a half-inch needle. My dosage is like 0.27 milligrams once a week, and the that was hard in the beginning. It was really hard because I had to get over the fear of needles, and it was really hard to do that. And I would like breathe heavy, and my heart would beat really fast. And it just now it takes me less than 5 minutes. I still feel a little bit of those symptoms sometimes, but I've developed the muscle reflex to just be able to do it. And um, I'm really proud of myself for that, because if you said a year ago that I'd be giving myself a needle once a week, I'm like, yeah, you're crazy. That's never gonna happen. So um, there are changes that have come with that. Even like just kind of like I guess that makes sense hormonally, but like in temperament and stuff too. Like, and I think the very first months, like my body temperature is naturally like warm, but I think since being on testosterone, it's definitely warmer. So I can just get hotter like a lot more easily.
Yeah.
Um, I didn't my menstrual cycle stopped after about I think 4 months. For some people, it stops like as early as 2, so that felt like a long 4 months. But I don't really have any symptoms of that anymore, and I do still wherever I place the needle, it itches a little bit afterwards, and even can develop like a small little lump there.
Hmm.
Now, a lot of these things, a lot of these symptoms, like the itchiness and stuff like that, when I mentioned it to the doctor, they really hadn't heard of it before. So my space where I went to things was Reddit. I don't know if you've heard of Reddit. It's kind of just another social media platform,
Yeah.
and they have a community for specifically like FTM Reddit.
Good. Perfect.
That really helped me so much in the beginning when I was starting out with tea, because I have all these questions like, hey, is this normal? Does this happen to anyone else? And people were able to give me solid yeses and their advice of what they did. And you do have to take it with a grain of salt, because it's a social media platform. Some of the people on there are like, 15 years old, and they so um like you can't take it as medical advice, but it was a really helpful community that really saved me a lot of relief in that time frame. um,
Yeah.
and I think as far as how that relates to like gynecology, one of the changes that I was kind of most preoccupied about and not really like in favor of was bottom growth, because I hadn't really spent much thought on that area anyway. I was
Mhm.
kind of like, okay, like if nothing needs to change down there, the thought of it changing kind of weirded me out, and I didn't really know what to expect. And I think also having some sort of idea of what to expect would have been helpful, because
Yeah.
for everything else, they can kind of say, like, okay, expect this. this might look like this might look like that. There's still no real examples of like, hey, this is an example of what bottom growth looks like. You
Right.
really have to dig and search for that. And it's not on medical websites that you find
Yeah.
it.
So
So,
let's go a little granular. When you say bottom growth, you mean the clitoris gets bigger.
yeah, it enlarges. And even how you were saying, I actually watched a documentary not too long ago, just about sex.
Mhm.
And it was even, I didn't even know what you had explained until I watched that a few weeks ago, that like in the fetus, like everyone's thing is the same. So, you know,
Yes.
like the clit is what is a penis. And, you know, even like the stuff surrounding that, I forget what the words are, but that's like the same skin that makes the scrotum. I had no idea about any of that.
Isn't that
So
crazy? Yeah.
yeah,
Yeah, the labia majora are
yeah,
actually the scrotum, you know?
that's so
Yeah.
crazy
I
and
yeah.
cool.
Yeah.
And it also makes a lot of sense because that like what I have now definitely more so matches like a penis. And I wasn't really expecting that because you just didn't know what to expect. And that's what I mean. Like, that's a change that I would have wanted to be able to expect. Um,
Yes, for
and
sure. That's
have
true.
an idea of, because people also don't talk about it as much, like even like trans men on YouTube, because they have to talk. Nobody really, not no one, but few people are not comfortable enough to go out onto YouTube and talk about, you know, their private parts
Yeah.
in detail. So
Yeah.
a lot of people are very vague about it, and that's totally understandable. But and for someone who is going like towards that and not knowing what to expect, that vagueness though, it doesn't really clarify anything. So I kind of just had to figure it out through experience, and whether that went from being something that I didn't want, that's actually something that I'm very okay with now, and I actually am pleased with as an outcome from testosterone, because that's one of the few things that does not change. Like they pretty much said, if I ever decided to what they call detransitioning, which is essentially if I were to like stop taking testosterone, like
Yeah.
certain things would change back. Like I would eventually get a menstrual cycle again. The fat redistribution would redistribute. And just briefly to touch on that, the fat redistribution was also a reason why I wanted top surgery, because I wasn't like in some moments I felt like because my chest was smaller, I was like, okay, I guess I could live with this and binding with this because of how it looks now. But with fat redistribution, with being on T over time, the fat really just kind of goes away from that area and goes to different parts of your bodies anyway. And they just like the breasts then just become like really just kind of like deflated.
Mhm.
Um,
Yeah.
and so
Help us understand how does fat distribution change, from a sort of female fat distribution to a male fat distribution?
it's really different for everyone. I it's funny when I was able to notice it over time, and I feel like I didn't really do a lot of the noticing. I feel like for some things I did, but I felt like my partner really noticed a lot of the changes, and then I would be like, "Oh, that is different."
A butts
But
list.
right. And so for me, I noticed that I had more in like my shoulder area. And I realized from Reddit too, that is a place that people just it becomes kind of more defined and just larger up in the shoulder area. And so I think more fat changed to there. And also I didn't really have a butt before. Now I do. That's somewhere that the fat went. So but I think it's different for everyone where the fat redistributes to. But
Mm,
essentially, just kind of like over time, you notice like, okay, this looks a little bit different than it was before, and my body hasn't really built fat in these places before, and now it is. And it's just kind of your body changing to a more masculine frame,
mhm,
because like where the fat is in like a like a female's body
mhm,
is again set up for reproduction. So that's why the fat goes there. So if you're on testosterone and you don't have estrogen to that extent in your body anymore, then the estrogen's not saying, okay, fat, go here. Now the
Yeah.
testosterone is saying, okay, go here instead.
You're impressive.
Thanks. Yeah, so I know that was kind of a trail off from what we
That's okay. It's
were originally
important.
talking about with
I want
testosterone.
to ask who puts you on the testosterone? I mean, who is there a separate physician after Dr. Nazarian does the top surgery? Then
Mhm.
is it someone at the Haddonfield practice who's I just want people to know where
Yeah,
they go, what they would do, and what's the program? Is it months,
so
years,
I
forever?
think that for some, I think this may vary depending on practice. I know for some people, like I know that for me, in my like case for being, cleared for as far as like the gender affirming doctor goes, like being on testosterone was something that they said like, okay, here's more proof that this person is like trans enough to get top surgery. But again, like not all people who get top surgery are trans or want like hormone replacement. But I know for some things, in order to be cleared for top surgery, you have to have been on testosterone for like 1 to 2 years. And I think also for bottom growth, you have to have been on T for at least 2 years. But that actually makes a lot more sense because I think that most of the changes on T have peaked around the 2 year mark. Like your voice changing has peaked around the 2 year mark. And that's another change that's irreversible. It was really those main two, bottom growth
And voice change.
and your voice changing. Yeah, because it's your thyroid is that the thing, and I don't know what it is,
It's
but
okay, it doesn't matter. It's in
within
that vicinity.
that family, right?
The voice box, right? It's
Yeah, that.
changes occur there in the vocal
Yeah, I
cords.
know that it
Yeah.
expands, and that's what creates the Adam's apple, which I have now, and
Wow.
not something that shrinks. So pretty much anything that grows is not going to shrink back.
Yeah. Yeah.
And so those were really the only two non-reversible things from testosterone. Um, but yeah, I kind of forgot what your original
No,
question.
it's okay. I mean, I love that you just freeform taught us so
Sure,
much. I mean,
sure,
I can't thank you enough for this. I
sure.
think we should probably wrap it up because I mostly tell people this is just an hour. So
Yeah,
I
sure.
know that this was far too interesting and you were far too eloquent to stop.
Thank you.
Yeah, I think you have a career somehow in this, but I just don't know where and when yet. But you really don't know how much you will inspire people and educate people by what you've said tonight, Angelo. And uh,
Great.
I applaud you for your bravery, actually, for saying I don't need to be private about this because by being public, I can inspire and educate and empower other people who might have these thoughts, but just not know where to go, what to do. Of course, I'm always indebted to Dr. Nazarian for her willingness too to take time out of her crazy busy life. Although I have 4 kids, you only have two, so she has lots of free time. I'm kidding, my kids are
Right.
gone now. But it really is important. I think things like this are very important. And while you were talking, I was actually getting some ideas already for the next one. I want to do
That's
some of the
great.
trans patients I know and some of the patients who've been on podcasts that I've listened to that have been super inspiring. I think it could be really neat to get a little forum together. We have a women's health expo this fall in Princeton, New Jersey. So I was thinking of inviting you guys to that to see if you'd want to have like
Yeah.
some sort of breakout session so that if people wanted to learn more about the Haddonfield Clinic, maybe we could get one of the providers from there and have you guys come out this fall. And I just love to meet you in person, of course, but also, just to be a place physically where people could come and talk to you and just have a talk could be really, really great.
I'd love
Um, yeah, thanks. Thanks for your time tonight. Thanks for your courage. Thanks for being eloquent. And of course, for having the megawatt smile. And
to.
Dr. Ari, thank you for bringing Angelo to this show because we really need to tackle some of these, I think, gaps in healthcare so that the patients who aren't getting seen or attended to or um, getting help can know that there's a place. My practice is called Women's Healthcare of Princeton, which even the name is sort of limiting. But of course, I named it 15 years ago when I really wasn't thinking like this. And yeah, we have trans flags and LGBTQ flags, and we try to be progressive and proactive. But you guys help me to understand that we have further that we can go, and that there are practices like the one in Haddonfield that can really both streamline and broaden the scope of what they can offer a trans patient that we can't. So I'm grateful for that, to know how we can be better just by being a resource to that Haddonfield practice. So thank you guys. This is Pride Month this month. And so every Thursday this month, this show, Gynecology, will be addressing LGBTQ issues and the continued struggle for LGBTQ rights in healthcare, among other places. So that's so that I say that so that listeners will know that we're not done here yet tonight with the LGBTQ story. This is just one very important aspect of it. I thank you both so much, and I really hope we get to meet this fall. Look for an invite from me, and it'd be my honor to have you there. Any last comments, Dr. Nazarian?
No, I just think the fact that you provide this forum is really spectacular, and I think you do a lot for a huge community, not just this community, but in demystifying various aspects of our bodies and our social existences. So thanks for the privilege of coming back. And Angelo, you're a total rock star. We need Niambi next time.
Yeah. Oh my God.
But thanks for sharing so freely, and I think that I'm sure you've helped a lot of people. So
yeah,
I'm just really, two thumbs up to everybody. Thank you.
Yeah, Angela, do I have Dr. Nazarian? I'm going to share this if you don't mind, Susanna. She sent me a picture of you and Niambi. I was like, oh my God, can I post that on our Insta, just of what a beautiful couple you are?
Yeah, sure.
I did, the one with the shirt on, I think, is what you.
Yeah. Whatever. Yeah, exactly. You
Yeah.
tell me which.
Yeah, they're gorgeous.
Yeah, they really are. You two are. Whoa. Anyway, thanks so much, guys. Have a good night. Have a great summer, and we'll talk to you again. Okay.
Take care. Bye, Angela.
Bye.
Thanks.